Actually, since you're
Please vote.
recording, I can now have on the recording that I've known Louisa since both of us were pediatric residents, and she's a lot younger than me.
So I just want to go over some basic tasks first, since this is a CME program. There's just some things that we have to go over first. So again, Alice is the Associate Dean of Education Skills Development and Vice President of Faculty Development at the School of Medicine. She is also someone who created a master's program just dedicated to teaching and leadership, which has been an amazing journey with her. This is the live session, which will be recorded for asynchronous viewing at a later time. That will be available tomorrow. Just to go over official business first, I do have to read this out for you. So based on the joint accreditation statement, in support of improving patient care, Northwell Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. We do designate this as one live activity for one AMA PRA Category 1 credits. For the recorded session, it is going to be the same amount of credits, and physicians should only claim credit commensurate with the extent of their participation in the activity. This is an overlying program. It's just an ICE and ACE CME program. The overall goal is to support and enhance teaching skills of the faculty involved in the preceptorship. The title of this series is Faculty Development Program in support of the Learning Associated program. That goal for the series is to just give clinical preceptors little tidbits to enhance their knowledge, skills, and comfort with clinical teaching in the ambulatory setting with medical students. And especially now where there's a little bit more stress surrounded in life in general, both with teaching and practicing and having students in the office. So the following information is provided for those who are viewing the recorded information, recorded version of the live session. This will be available for everyone to view on March 3rd on our faculty development site. To receive credit in the chat box, if you can just put your name, credential, and email address, Dr. Sharavu will be taking attendance to make sure that everyone gets their credits, or we just follow up with you and give you links through your email for the entire program. If you are watching the recorded session, your attendance will be via the survey at the end of this session. Again, please only claim credit for the amount of time attended. As far as disclosure, we have nothing to disclose. It's myself, Sunita, Alice, and Michael Parrish who've been putting this together. We are open to any feedback anyone has and any future sessions that anyone wants to receive or learn about. So Alice, you can just give me some next, and whenever you're ready, I am ready to next.
Great. So these are objectives. Obviously, I am an educator, like Razia said, and Razia is an educator as well. And these are objectives of what we're going to cover tonight. And I hope this is very informative, but most important, practical and skill-based for you. So next slide. So the big question is, what is feedback? So honestly, if I said to you right now, go into your phone and Google feedback, you would get so many definitions of feedback. You really would. There's many versions of the definition. So what I put here is feedback is the information you provide to learners about their clinical performance that is intended to guide their future clinical performance. So thinking about feedback, I want to frame it in a coaching model tonight. And I think that's really important. So what we're doing tonight, if you look at this diagram, look at this picture, what do you see is the difference in this picture between the two images that are on the page? And this is just talk. Unmute yourself and talk.
I'm going to just say that I see the first picture is most striking because I see someone running away. That's the first thing I see.
So this is, and what is between the people? What would you call that image, between or behind the people in the second image? What would you say that is? Anybody? Any volunteers?
It's a fence that separates them.
Thank you, Ona. How are you? Nice to hear your voice.
Thank you.
So it's a fence. And many times we have barriers in between between the person receiving the feedback and the person giving the feedback. So this is to represent that there are barriers. And many times what we do is we just throw the information at the learner, like, you know, next time you do that procedure, maybe you should consider X. Or the next time you talk to the patient about, you know, tests, maybe you should do X. And you sort of just throw information to them. You don't know if they're ready to hear it. You don't even know if they're listening, but everybody's in a hurry and you're sort of saying, you know, next time do this. Or even if you want to give good feedback, you know, you did great at X. But in a coaching model, you're sitting down, you're talking to each other, you have eye contact, you're face to face, and there's no barrier between the two of you, and you're looking to help the person to get better at whatever it is. So we're promoting this coaching model more than we are the feedback model. Any questions on coaching yet, or I'll continue? Any further comments on the image? Okay, great. So one of the models that talks about coaching is the reflective model of feedback and coaching, and it's nicknamed, or it has a acronym name, I should say, R2C2. That's pretty easy to remember. It sounds like some robot, R2C2. And the first R is relationship building, that you must have a relationship to do this well. Well, all of you have students in your office longitudinally, so that's a relationship. Then you must explore the reaction that the person has to the feedback. So you must be looking at them and seeing how they're reacting. Is it making them nervous? Is it making them happy? Do they seem very sad by what you're saying? What is their reaction? Do they seem not to care? Then explore the feedback content in a very exploratory way. This is what I saw. This is what I heard. This is what I observed. And then you want to coach for change. You want to have a moment of talking about how can things be improved next time. That's the coaching for change. And what I gave you here, I'm sorry, I don't have the reference for this article on the slide. I do have a reference for it though, is two statements that came from this article that when they use this model as a coaching model, it prompted them to think, the residents said, differently about providing the feedback and receiving the feedback. And it really helped to have an opportunity to coach for improvement and to make the whole process positive. Because many times when you say feedback, everybody gets nervous, everybody tightens up their chest, their blood pressure might go up a little, and that nervous system response is coming, and you're like, what did I do wrong? So it puts more of a positive light, the coaching. And it's very helpful, it says here, this is direct from the article, that it's very collaborative for the learning relationship and it reduces the anxiety. So that's what we're trying to do in this coaching model. Next. A woman I'm very, very friendly with, or there's actually everybody on this author line of this article, Feedback, Redesign, Principles and Practice, is an amazing medical educator, every single one of them. And it says in this article, it's essential that clinical teachers observe learners' performance. And this is the point of what I want to say here. When you're defining feedback or coaching, if you've not observed your learner, if you've not heard them say something, if you've not seen them do something, you're not really debriefing an observation. So just to say, don't do something if you didn't see it, or do more of X. If you did not see it, it's not good. You need to debrief observations and it needs to be timely. So in the moment, if it can't be the exact moment it happened, at least within the session that you're with the learner. And you always want to encourage self-assessment and reflection. We'll talk about that more, the importance of self-assessment and reflection. So this is a great comparison of feedback and coaching. And I love this comparison where feedback focuses on the past and coaching focuses on the future direction, future change. And then the difference here where feedback is very reactive and coaching is very proactive. So you want to be proactive, not a one-way communication, two-way. You don't want to tell, you want to ask, and that gets into the self-assessment. How do you think you did? What would you like to do differently? How are you going to practice to improve? The asking, the asking, the asking, asking the learner. You want to unlock potential. That's the most positive thing you can do with anybody. Everybody has potential, and you want to unlock that potential as the teacher. It's such a rewarding moment when you do that. Explore options and alternatives. That's always important. Don't make it, be very consequential. If you don't do it this way next time, X, that's very consequential versus what are the options for making the change? And you hope that the receiver in the coaching model is very self-motivated to take responsibility and find their own answers. Take responsibility and find their own answers. So it's not the giver who's motivated, it's the receiver. So this is a very important slide to think about. Any questions on this? Okay, go on next. You'll save all your questions for the end. So assessment drives learning. We say this all the time at the medical school. Sometimes you say assessment. So you always get data, then you ask for self-reflection, then you go into feedback, and then you go into the coaching and encouragement of your learner. That's bringing out the potential again. Have them practice again, and you get more data. So it's a very cyclical cycle, the whole process. It never ends. So there's no beginning and end. It keeps going throughout all the time you spend with your learner. Go ahead. Next. This is a great article. It's called The Doctor Coach. Okay, The Doctor Coach. And what's great about it, once again, it's reiterating the same thing, a performance observation, your assessment as the coach, giving formative feedback for improvement. That's what formative means, to inform that, help them set a goal of how to improve, and then facilitate that practice happening again. Once again, a cycle. Up here, we're not concerned in ICE at all in terms of summative evaluations. That we're not concerned about. So you're really only in this circle as a doctor coach. In some other settings, like in terms of if you're a fellowship director, which I think some of you said you were, you might be getting data from your faculty that will inform a summative evaluation. This is important for Beth. And then thinking about what's happening with the learner. But this is outside of the actual doctor-coach relationship. And it's ideal that a coach is not doing the summative piece and that the coach is totally focused on the formative piece. That's an important principle of coaching. Go ahead, next. I'm not going to show you this YouTube video tonight, but you will have the slide deck if you want to look at it. It's a great cartoon video to talk about Ask, Tell, Ask. And Ask, Tell, Ask, we call it SFED at Northwell, self-assessment, feedback, coaching, encouragement, coaching, and direction, which is self-direction by the learner about what they want to improve. And I'm going to go through that, but it really is the same as Ask, Tell, Ask. And this video is a cartoon video about it if you want to look at it. So we have self-assessment is the A. The tell is the feedback and facts. And this is factual information. I saw, I heard. It can't be hearsay, like you're on the witness stand. Encouragement, you give with your coaching motto. And in the coaching, you come up with direction of what will be done differently next time and how will the learner be able to do it differently. So that's sort of the ask, tell, ask model. Next. This fits into our SFED model very nicely. This is an infographic of it. And this is self-assessment, feedback, and facts, ask, tell, respond with encouragement and coaching. And then the ask is the what do you want to do to improve? What would you like to do? And then challenge the learner to reach their potential again. And these are questions here that you could actually use, like to do differently. We don't even ask what was your strengths, what were your improvements. We use the words very specifically. What was effective? What would you like to do differently? These are very deliberate words. This is what I saw that went well. This is what I saw that needs improvement. How can I support you? I have confidence you're going to be able to be successful, and come up with a coaching plan. And then what would you like to do first? And if they can't come up with anything, you can suggest something. How often would you like to check in? Next. This is one of my favorite articles, and I feel a little scared every time I show the slide because I feel like this article came out yesterday and now it's 6 years old. So it didn't come out yesterday, and it's a great article on cheerleader to coach. And the reason I love this article was the title. It said, everybody likes to be a cheerleader, but what we really need is a coach. And we need a coach that is able to give feedback to our early learners. And all of you in ICE have very early learners. So you are all need to stop being cheerleaders, and you need to be coaches. Next slide. This article has a number of diagrams in it, but I'm just showing you one, that when people are less experienced at this, they're generally cheerleaders. They don't make the learning environment challenging enough. You want safety with challenge. You want a balance there. The delivery is generally private one-on-one, which is fine, but sometimes you need to be able to give feedback when you're in front of a team. Most of you are doing one-on-one feedback, so that's okay because you're in offices. Back 1 second. Back. Over here, the educational focus is the current needs, but here you're really focused on developmental trajectory. Where are they going? What's the next step? What do they need to be able to do? You're not just focused on the current need, you're looking at them develop. And then you want you want to develop resilience. That's again, looking at really looking at their potential. Build resilience when you give the coaching model. And you want to be very goal oriented. With coaching, you're always striving towards goals, and you're making those goals, okay? And the article is linked right here. Okay, go ahead. This is an example of the SFED model that's in my new app called Just-in-Time Teaching Infographics. You must put into the App Store or Google Play, JIT Infographics. You must use the word infographics. I'm sorry, it's not on the slide. And in there are teaching apps. These are under the foundational teaching apps. And this is taking the model and making it readily available on your phone to remind you what to do, to self-assess, to tell the facts, to encourage and coach, and then give direction. And this is, once again, right on the app that you can download to your phone called JIT Infographics. And there are many teaching tips. And I just want to use this moment to say, this is a series we've been doing. And if you've not been here before, we started out very much so with the first step, which is setting expectations. And that was the first thing that we went over on our program. So you can go back to the app if you forgot or you couldn't join us for whatever reason. There is a JIT on expectations and goals. Set these with your learner, which is the first step in any teaching. And then there's another JIT on something we went over, which was the micro skills of teaching, the 5 micro skills of teaching, and how to precept with limited time. And we did that as well. And then there's also a JIT on how to incorporate the social determinants of health into the expanded social history, which is something else we went over that we're trying to encourage. There's also a JIT on how to ask effective questions to your learner, and that's also on the app, and how to create psychological safety in the clinical environment, and is in the app. So all these tips that we've gone over in prior sessions, how to teach with the patient in front of you versus how to teach when you're not with the patient. So there's 2 types of teaching in front of the patient and teaching outside the room when you're just with the learner. And we have apps, we have JITs on how to do bedside teaching. These are all sessions that we've done in this series and are very important. So they're all on the app under the foundational category. So please download the app. It's free and it's in Google Play as well as the Apple Store. Next, please. So I'm going to go back to this because this is really looking at how to get a learner to use the Ask, Tell, Ask, our SFED model. But I'm going to come back to this slide after. So the 4 components of feedback here, once again, this is a summary slide, is the self-assess, observation data somehow, then the coaching, direction, and encouragement. So next. And what I like to do is take the old Oreo cookie sandwich that we used to use with positive, negative, and then positive, which is not good because once you do the positive and then they hear the negative, if you don't have anything else positive to say, they're left with just the negative. So what we call this is, what did you think you did effectively, the positive? And then you get into a collaborative feedback model. What would you like to do differently next time? And then you end with direction and coaching on how they could improve in whatever way. And we call this a collaborative feedback sandwich. And it's a much higher quality, but still with a good Oreo cookie always, if you like Oreo cookies. So over here, this is a slide that sort of just diagrams out that you observe. Everybody makes judgment after you observe. Even if you don't have a checklist, you're making a rating about that person. Oh, that was excellent, or that could be improved, or, you know, it was okay. Then you give your feedback, but you must always end with the coaching, as I said. Next. I love to talk about this slide. Dr. Schlegel and I, who's on the call here, was at a conference in Ottawa, Canada, when we were able to travel in those days. And this slide went up, and it's feedback as an education alliance. So everybody should think about this model of giving feedback as a mutual understanding of the purpose of the goals, an agreement how to work towards those goals. That's coaching, having a goal and working towards it. And the learner trusting and valuing that teacher. So if you think about coaching in the world of sports, or you think about coaching in the world of music or theater, anything, you really have a coach that you trust. And when they say, hold the bat this way, kick the ball this way, put your hands on the piano this way, or the violin, or when you're on stage, make sure you have a certain stance. You listen to that person, you trust them, you value them. And that's what the coaching relationship should be here. It should be an educational alliance. And this comes from Canada, really good people, this concept. Next. So how to teach mindful anything, be mindful, how to be mindful. You should always be mindful when you're reviewing things with your learner, mindful of the right amount of information. Don't comment on 6 things they did. Pick 1, maybe 2 things you want to comment on. Maybe 1 on the history and 1 on the physical. Our goal of ICE, and I'm speaking to ICE more than ACE, is at the end of ICE, which is 2 years for us, that they can be so comfortable with history and physical going into their clerkships, no matter what the clerkship is, medicine, pediatrics, OB, psychiatry, surgery, anything, they should feel comfortable with history and physical. If they can do that well, based on your coaching, you've accomplished so much. That's our goal. But you want to give the right amount of information in the moment, not overload it. You want it to be developmental also. So you need to know their gap in knowledge and skills. That's how you identify what developmental level you should be giving feedback on. If someone can do a basic physical exam, maybe you want to give feedback on the cardiac exam, and that's an advanced skill. But if somebody can't do the basic, you don't want to be giving feedback on the cardiac. And if someone can do a really solid history on the history of present illness, then maybe you want to work on their social history skills, or vice versa. Mind the amount of time you have to do it, because that's going to govern how much feedback you can go over. Mind the student reaction, and once again, the body language. Be mindful of the feedback you're giving. Think about what you're saying. And monitor the stress that someone's the challenge. Remember, the challenge is okay, but you don't want it to be too much. You want optimal challenge with optimal um, no challenge. You want it to be a balance. It can't be one or the other, too challenging or no challenge. It has to be right in the middle. And be mindful in the moment when you're with those learners. Be with your learners. Next slide. Oh, I don't have my beautiful new slides I made for this. Oh, okay. So I got all these ideas about coaching from Atul Gawande. He wrote an article in New Yorker many, many years ago. You can Google it. It comes right up on Google about having a coach. And if you don't know Atul Gawande, maybe people do, some people don't. He's a very, very famous surgeon in Boston at Harvard, of course. And he is in the operating room all the time. And he talks about the need in this article called Personal Best. It was a very famous article when he wrote it. It still is. And he talks about the need a coach, the importance of a coach. And here he is, a very skilled person, and he has a coach come into the OR with him. And he talks about the factors of what makes a great coach and understanding that the details create success, that small things make the difference between good and great. And that's not just true in surgery, that's true in every encounter you have as a learner with a preceptor and a learner with a patient. And you want to have humility when you're doing this coaching. You don't want to be ostentatious or insincere. You want to have humility and be able to engage as a team. Next. So in my conclusion, before I go back to some practice slides, this is another person, Judy Bowen. And I just want to recognize that all of you have a very challenging job to do clinical care and teach at the same time. And clinical teachers, as she said, she wrote this in the New England Journal of Medicine, one of the most prestigious medical medicine journals. It's not a medical education journal, really. 2006. So and she's still going strong, Judy Bowen, very strong. She's a guru on clinical reasoning. And clinical teachers differ from clinicians in a fundamental way. They must simultaneously foster high quality patient care. So we never want you not to do high quality patient care because you have learners with you, and assess the clinical skills and reasonings of those learners. So you're doing two things in once to promote the progress towards their independence. So as a clinician educator, you are doing both. And you must diagnose the patient's problem and the learner's ability and skills. So you're doing two levels of diagnosis when you're a clinician educator. I think there's one more slide. And it's great. Sometimes you think, oh, this patient is nothing interesting for the student, but a good clinical teacher can articulate what seems different with every straightforward patient. And with repeated exposures, physicians can fully be present and learn to unwrap the puzzle of the patient before them and do this with your learner. So she really is talking to you about somebody who brings out the hidden pictures that are in a puzzle sometimes. And that's a great way to think of your role as a clinical teacher. And I think that's the last slide. So I want to go back to this slide here. So if we thought about scenarios, and I thought we could actually go maybe in gallery view, but I just want to go over this, that if you wanted to give in the ambulatory clinic setting, many of you in ambulatory, a learner feedback that they, their note was not what you expected, or in this case, they didn't read the EMR before the health record, the EHR before going to see the patient, so they didn't have the background information on the patient. I want to talk through some of these scenarios to think how we could give feedback. If there are any surgeons, I didn't get a sense there were surgeons here tonight, but if someone didn't do the suturing right and you gave them the opportunity to suture, or they didn't hold an instrument right, how would you coach them through this feedback? Or, that. So if they're taking too long with a patient and they're a young learner developmentally, how would you address that? So there's different things we could talk about, and I thought we could do that together. if you'd like to go, but it is important to identify performance, knowledge, and gaps, and whether it's knowledge, skills, or attitudes when you are giving feedback. It is important. And the model here of ask, tell, ask, or self-assess, feedback, encouragement, coaching, and direction. Go ahead. You can take off the deck now. Oh, let me turn, it got dark out.
So I'll share those slides again towards the end of our discussion, just so you guys can all see the CME links for that. One thing I did want to say, so I've been working with Alice for some time, and I think, you know, in resident education, one of the important things that Alice goes over is really doing that ask, where we ask the residents first, because I think just giving blanket feedback, and where one learner may have thought that they did a great job versus another learner who was not so confident in what they did, and you're giving not so amazing feedback to someone who thinks they did a great job, right? It won't be received the same way. So I think it's always important to find out how they thought it went, so that you can kind of follow through with that conversation accordingly.
It's very important for the learner to speak first. I don't think I said that. And that, you know why? So just think about any conversation you're having. And whoever speaks first sort of takes it, owns it, any conversation. So when you get into a room with the learner, or in the hallway with the learner, and say, so how do you think that went? And they sort of look at you with a blank face. They're like, oh my God, they want me to speak first. Sometimes that's a little shocking, but it's very important, because the minute they're speaking first, they're engaged in the conversation. The minute you're speaking first, they're sort of checking out. They may not be listening to you. So it's really important that the learners speak first, and you engage that by saying, so how did that go for you? And if they look a little shocked, you could say, well, what did you think you did effectively? Many times they'll go to the negative, and if they do that, then you could say, okay, let's talk about that. But also, did you feel you did anything effectively? Well, I felt the patient was comfortable with me and was able to sit and answer the questions I asked. Yes, that was great, you know. So it becomes a conversation between the two of you. It's not that throwing of information at them, it's a conversation. So that's really important. It's probably the most important thing of everything said here tonight. So thanks, Razia, for emphasizing it.
So I always find
Any
with
comments?
these, yeah, does anybody have any comments on any particular situations that they've had with students where they've had to give feedback and it went well or it didn't go so well?
Nobody's bringing up the elephant in the room. Everybody usually brings that up. What's the elephant in the room? You're all thinking the same thing.
It's easier to be a
What's the elephant in the
cheerleader.
room? It's easier to be a cheerleader. Yes, and takes less what? Takes less. That's the elephant in the room.
Always time.
Time, thank you. Time is the elephant in the room that nobody's bringing up. But you could actually do this quite effectively if you're going on one point. Everybody feels I have to talk about everything, all the things he did with the patient. It becomes so overwhelming, like there's no time for that. But if you can help a learner improve on one thing, one little thing, they're going to feel so much more satisfied with the experience. So you saying I have to talk to them about so many things, there's no time, let's go on to the next patient, versus saying, so how did that go for you? And then you saying, this is what I saw. When you asked the social history, I don't remember you really asking about, you know, drugs and tobacco and all those things. What were you thinking? And the learner might say, well, I forgot. And you might say, well, how does that impact, you know, forgetting that information, considering what he's coming here with a cough as his chief complaint? Well, I guess it would be important to know if he's a smoker. That would be important. Yeah, that would really be important. And his smoking history would really be important. So that might impact your differential diagnosis. So that's really important. So how would you remember next time to ask about smoking? What would you do differently next time? Yeah, I always forget that social history. It has so many things. Like sometimes I ask occupation and sometimes I don't. And well, how are you going to remember to ask all the things about social history? What's going to help you? And somebody might say, I'm going to start with their personal life and then I'm going to go into their work life. Somebody comes up with some plan because there are a lot of variables in the social history. Or how just like they use the acronym to ask about the HPI, the history of present illness and the chief complaint. We taught them an acronym so they remember to ask all those 7 characteristics. Well, if you remember that acronym, you learned it in medical school. Right?
I just remember the LMNOPQRST.
Right.
Okay.
That's it. That's the acronym. You got
So
it.
Alice, so one thing just to say is that, so I do inpatient, so I know you guys all do outpatient, so there's like, it's very different beasts, right? So what I usually say is if you're gonna have the students see 3 patients for the afternoon, if you can give them that kind of coaching and feedback for 1 patient, then that's adequate as long as they have like one big takeaway that they can from that session, because the overlying goal is really to get them comfortable with history and physical communication skills during their time. So it's not to make them an expert in any one condition, because they'll learn that, throughout their 2nd, 3rd, and 4th year. But it's really to hone in on communication skills. Now, Alice, I know that Sunita and I were going to do a role play, but I have a question because I always like to observe the expert doing the expert thing. So can I play the student again, Alice, and you do your feedback coaching like you did yesterday?
Sure.
Okay. Because Alice does it really well.
Can I just ask one thing?
Sure.
Yeah, of course, Russell.
I got to see a couple of the different students this year, and one in particular had 0 self-awareness. And when someone is self-aware in some fashion, even if they don't know something, they can learn from it. What do you do with the person who looks like he wants to be a surgeon and has no self-awareness?
So I'm going to let Sunita and Razia answer, or anybody else in the group. Anybody can. You're asking a challenging question.
So Russell, something that I've done inpatient, and I think, having taken that master's with Alice was super helpful, because I think just that asking them how they think they did, and hearing that they think they did such an amazing job, or they, had no idea that they, were chewing gum in the session and blowing bubbles, which is highly unprofessional. So I think just asking that question is definitely a starting point, and then just to kind of go with, well, these are the things that I observed happening during the session. How do you think the patient felt, or kind of trying to see if they can recalibrate on how the patient felt. And I think it depends on the situation, but I know I had one like really tough learner when I was at Forest Hills, and he was just, he was just very mean. He was just very mean and very dismissive. And there were a lot of different things at play. And, whether it was a female patient he was talking to, or culturally, there was like some concerns there. There were a lot of different things at play. And I just could not get through to him. He would not listen to me. He was about 20 years older than me, doing residency again here. And, one thing that got through to him, I tried. And one thing that I decided was that let me go ask the patient what their perceptions are. And during a session, I said to the patient in front of him, I said, hey, I'd like for you to give us some feedback on how we are doing. And when the patient gave him the feedback that you don't make eye contact, you talk to me like this, you do this, and I had no idea what the patient was going to say, but she thankfully said what I was thinking. It was like this completely eye-opening experience for him. Like, he was in tears. I couldn't get through to this guy for 2 years. Okay. And so I tried different avenues, but it was the patient-centered part of it that I was just like, we all go into medicine for a reason, right? It's just to serve patients and take care of patients. So I said, let me try that way. And that opened the door to a conversation that I was able to have with him. And we had a very long discussion, kind of like a coaching style one, where he became aware of how he was coming off, how he was talking to people. So I found that beginning question of how do you think you did just such a great foundational framework for you to then continue having the discussion. So, okay, so you think you did a great job. These are some of the things that I observed. I don't know.
Because sometimes these types can be very frustrating, but I
Mhm.
also think it's important not to lose hope or not to give up with them. I know there was one many years ago who was probably the worst pediatric resident I have ever seen. I can give you stories. I'm not going to give his name. He was abominable. And I even went to the chairman to say how bad this guy was. He came to me 2 years later and said he wanted to have a closed door meeting with me. And I was almost afraid that like he's going to like get in the fight with me because he must have heard what I said to the chairman. And he actually said, I want to thank you because you were the only person that was honest to tell me what I needed to hear. And I just wanted to let you know I'm going into radiology. I'm leaving pediatrics.
But
So
also, let me explain. The other thing that's really important is it's very hard to make someone self-aware that you don't have a relationship with. So you may not be the person to make that student self-aware because you may not have enough relationship with that student. Because you need to have a relationship. You need to talk to them. That's what coaching's about. So you might say, I'm really concerned that you may not be so self-aware on some of the things I'm concerned about, but perhaps you want to talk to your clinicals, like Razia or Sunita, who are leading this ICE because they have more of a relationship with them. Because not having a relationship, it's very hard to do the coaching. The other thing is that ideally with someone who's really struggling for whatever reason, be it attitude, be it skills or knowledge, having a longitudinal relationship, not an in and out relationship, is helpful. And we have techniques at the school to help with that. So it can't be that it's all on all of you here. If there is a challenge, there are other resources to help. And it will take a lot of time for an unaware student to become aware. So we don't expect that of a precept of being able to put all that in, but certainly between the teams at the school, there are opportunities to make things better.
Yeah, just to add, I mean, that's a great question. The student or, trainee that lacks self-awareness, like that's always been a challenge for me as well. I think if you have the opportunity to have a longitudinal relationship with this person, then obviously your role modeling and how you conduct yourself makes a difference. And then for really challenging students, like I try to understand, like, what is their perspective? Like, where are they coming from? Why are they this way? Is it like a fundamental misunderstanding? Is it something that just hasn't been pointed out to them? And I try to work like from the perspective of where they're coming from and see how I can connect with them. But this is a really challenging, challenging person to work with and to educate.
I think one additional thing, Alice, is that I think having the insight of ourselves and how we are behaving also is like very important, like Sunita alluded to. Like I've had, residents say, oh, you rolled your eyes during that interaction, like, and I didn't even realize it, right? So for me, like, during COVID, Sunita and I are dealing with, like horrific things that have been said in certain settings by both preceptors and students. And I think sometimes we forget so often, like how much every little thing that we do is role modeled to students. So for me, like, my residents are incredibly scared of me, but they are open to talking to me when I self-reflect on all of my, shortcomings. When I'm clinical, I'm like, oh my God, I forgot this, or I shouldn't have done that, or I did this. And I kind of have an open forum with them. Then it kind of makes them a little bit more comfortable to having those discussions. Alice, did we lose you?
I'll be right there.
Okay.
Sorry. I'm giving another talk right after here, so I'm just, they're getting nervous, the other talk. So I just want to say what you're saying is active role modeling, and there is no more powerful teaching tool than active role modeling. I just want to tell you that. There is nothing more powerful than being an active role model. And that's super important, to be an active role model. And everything you're doing, every learner is watching. And if you're doing something suddenly that you realize, I can't believe he saw me do this, I would just be transparent and say, I know I just did something that you can't probably believe you saw, but sometimes under stress, these things happen and it's not my best time, but I want you to be aware that I'm aware it's not my best time. So then you're teaching them self-awareness. You are demonstrating in a very transparent way. I can't be perfect all the time. I'm being transparent about self-awareness. So I think that's really, really important.
So in the last couple of minutes we wanted to do a quick role play, and I would love for Alice to kind of be the preceptor because
I'm
she
gonna
just
do
did it.
because then I have to run and
I know, we'll do it very quickly, Alice, because you did
okay,
it so well yesterday.
3 minutes to do it because we want it to be short to show you that it can happen in 3 minutes.
So the scenario is, I'm a medical student. I just interviewed someone with chest pain and I had 15 minutes to do it in your office before you want to send them to the ER. So Alice, you start.
So thank you for interviewing that patient. I know the patient might have been a little challenging, so I appreciate you doing that. So how did you feel that went for you, Razia?
I mean, I felt a little stressed out because we had such a short amount of time to interview him. So, I mean, I think I got some key components of his social history, but I feel like there was a lot more medical stuff I could have asked him.
So it seems to me, as I'm hearing what you're saying, that you're concerned that you didn't get enough history of present illness, perhaps, or even past medical history that's so important for diagnosis.
Yeah, I just felt that there were certain things that I wanted to ask him, but he kept talking about his family and work, and I didn't want to cut him off. So I just didn't want to be rude and ask him about, you know, the quality of his pain when he's talking to me about his family.
Right. So it's very hard, especially with patients who are very talkative somehow to, if they're a little tangential to what you're trying to do, and especially as a new learner, you're very organized in your, getting the history. I want to say you're very organized. So sometimes being tangential as a patient, that's hard. So what do you think you could do differently next time to help you to get the patient back on track, so you get the medical history, and then if there's time, you get a very in-depth social history? What do you think you could do differently?
Well, I'd like to just figure out how I can interrupt the patient and get them back on the wavelength that I want to be on for my review of systems without being rude and seeming careless, like that I don't care about the patient.
So that's a really good point. So how do you take a patient back? So what you can say in a very polite way, say, I am so interested in who you are as a person, but I know Dr. X is want to know fully about all your medical concerns right now and what brought you in. So I want to get all that information. And then after I have all that, let's go back and complete all the social history that you want to tell me. But I really want to be prepared so Dr. X is able to help you today, and I need more medical information from you. Will that be okay?
Okay, I'm concerned that I'm not sure how much practice time I'm going to have before our next session. So do you have any suggestions on?
Well, so, you know, for history taking and physical exam, you can always practice with somebody at home. So you could sit down with, you have a grandparent or an aunt, an uncle, the person you rent your house from, anybody, and say, do you mind if I just practice some history taking skills? And practice at home, because it really becomes a habit how you do this. So the more practice, the more natural it's going to be, and the less stressed you're going to be. So practicing with anybody at home, you know, physical exams a little more invasive, but certainly history taking, you could do that. How does that sound?
Yes, I can try that before our next session, and then you can maybe give me some pointers at that time.
Sure, I go in with you the next time and observe you and get the data, and we could talk about it. So thank you for being so honest.
No problem.
How long was that? It was a little longer.
No, that was 3 minutes.
Really, it felt longer.
Time off.
Yeah, but she spoke a lot.
Okay. The student was very reflective.
I'm a reflective person.
But also, I made her have the opportunity for reflection. You have to give the opportunity. You have to open the window.
Yeah, I like how the student took the lead and she was the one to pave the way for what she could work on, what she did well. I love that component.
And she asked me, what can I do differently next? How can I practice more? So I gave her that information. if I had more time in the ideal world, I would say, what are some ways you think you could practice more and try and get her to come up? That would take longer. So everything is time driven. So if you
Yeah.
wanted to spend 5 minutes, she might have been able to come up, well, I live with this person. Maybe she'll let me do the history on her and we come up with a whole plan. But since she asked me, I didn't throw it back at her, but I could have, but it was okay where I said that. And she said, well, that's possible.
And I think a lot of times, Alice, if you have to go, you go, and I'll finish off. I think a lot of times the student is going to come back saying that, you know, they did a terrible job, and then you can just inquire why they thought it was terrible, and then give them some, you know, positive reinforcement of the things they were able to do. So for this learner, you know, keep in mind that you're a new learner and you were able to talk to the patient. That's a big step. Like, you were able to get in there and get a history. That's the first big step. So trying to find some positive, because
What
a
did you
learner
do?
will always go
Yeah.
back to negative.
Use that well. I hear all the things you're saying, but you did something effective in that room. What do you feel? I went in the room and I sat down. I did it. And that's right. So you have to give them that developmental trajectory. Remind them who they are. They're a new learner.
So I just wanted to put some resources for you guys moving forward. I did, Alice has a lot of podcasts in general for the JITs that she generates. So I wanted to put those links on there for you to directly take you to the JITs. You will be getting the slideshow tomorrow. You'll also be receiving an evaluation and outcome survey. You'll be getting one in about 3 months, just to see how, you know, if you were able to utilize any of this information. They're very quick surveys. And that is really it. I really thank everyone for coming and joining us. And I believe we are stopping the recording. Alice, you can stop the recording, I believe. So we'll stay on here if anyone has